Cool, thank you. Okay, and then just keep admitting people for me. Great, all right. So this is recording now, so I'm going to share my screen. And you should be able to see this. Goodness me. Right, okay, can you all see my screen and hear me?
Yeah, thanks.
Fab. Okay, so as I said before, today is going to be about kidneys and urology and the immunodeficiency kind of allergy side of things. Both quite high yield things in lab med, but really, really easy to get your head around once you've learned the concepts properly. I'm a big fan of the fact that you can make this course significantly easier for yourself just by learning one or two very key things. So we'll get on to that. Okay, so with the kidneys and urogenital system, the things on the right are your syllabus, as you know, and the things on the left are the things we're going to focus on today. So these are the biggest things that come up and pretty much the cause of all kidney dysfunction as far as you need to know, or as far as I need to know at this stage in medical school. So we're going to start off with a really, really, really common case that you'll see in different forms in MCQs, whether it's AKT or LabMed, but it will come up all the time, is this concept of renal failure, which is pretty old terminology, and it actually comprises two separate parts. So that's AKI, which you've done, acute kidney injury, and chronic kidney disease. Similar but different, obviously, in terms of their timeline, but also in terms of what they do to your urine and blood. So this case is the kind of bread and butter of what you'll see. You'll see an old, probably bloke, but sometimes woman, presenting for routine blood tests, maybe has a bit of a history of difficult to control hypertension, but really not much going on. And then you find high potassium. What's going on? It is always, always, always renal failure, and they'll give you a ton of other options and freak you out with things like aldosterone and, you know, diabetes and other things that get in the way of your potassium. But it's always going to be this. If you see hypertension, especially really stubborn hypertension and hyperkalemia, it is an issue with the kidneys. So acute kidney injury has this definition at the top here, which involves lots of numbers, and you can learn them if you want. I've never found that they help. I find that diagnosing it clinically within a question is a lot more helpful. I know I never learnt the numbers. As you all know, there's three different categories, and that depends on where the AKI has started. So the first is pre-renal, and that is by far the most common that you'll see in the hospital day to day. That comes down to reduced perfusion, so whether that's blood moving less well or there being less blood going through the kidneys at any given time, hypotension, sepsis, burns, cardiac failure, all of those. When you think about hypertension, don't necessarily think about medical hypotension, but think about why you might have less fluid circulating at the time. So it is absolutely like bread and butter when you do your acute medical placements in kind of January to May time in the JR. You will see a ton of patients who the med reg will say, oh, she looks a bit dry, let's have a look at her urine. And her tongue's a bit dry, maybe skin's a bit dry, that sort of thing. And you look at the urine and it's really brown and really smelly. You might think UTI, but it's just so concentrated because they're just dehydrated. They're just old. Maybe they've had a fall. Maybe there's another reason they're not drinking enough. Either way, they've not drunk enough. They might have been laid on the floor for a bit of time, a couple of days, and they have an AKI just because they're dehydrated. The others are obviously also causes, but less common. Intrinsic renal, so you've got acute tubular necrosis, which is a bit confusing, and we'll do a separate slide on in a second. You've got the diseases and you've got the drugs. You don't really need to know the mechanisms in that much detail, as long as you know that it's going wrong within the kidneys. It's the least common cause of an AKI. Postrenal, classic obstruction, anything that gets in the way of the ureters, of the bladder, of the outflow from the kidney, urethra, anything, you're going to end up, everything's going to back up and you're going to end up not filtering as much as you were originally. So, as I said before, the test results that you'll get given in a question that should scream at you, this is an AKI, are really high potassium, maybe even ECG changes related to that high potassium, so those classic tented T waves, that sort of thing, and a metabolic acidosis with a normal base excess. Hopefully, as you'll remember, or there are people in the waiting room still. Hopefully, as you'll remember, base excess relates to cations versus anions. And obviously within AKI, you're not producing any more anions or cations or getting rid of any more than normal. Everything that's going wrong is being compensated for by something else that's going wrong. For example, you're not getting rid of enough potassium, so you're excreting too much sodium, that sort of thing. So normal base excess, hyperkalemia, metabolic acidosis. And you've got these other things which you may or may not see depending on the pathology. AKI presents in a number of ways. As I said before, the classic is how your urine looks. And as we talked about in the lecture yesterday, pericarditis can be secondary to high urea. So that'll give you chest pain, that classic pleuritic chest pain, which is worse when you lie back and better when you lean forward. I am just going to check the waiting room 1 second. There we are. Sorry about that, guys. Okay. And obviously, as always, if you have any questions or anything that's confusing, pop something in the chat or just interrupt me. I want this to be as interactive as possible without actually asking you questions, because that's quite awkward. Right, let me share my screen again. Fine. All right, so AKI, as I said, is going to present with the really funny urine, really brown. You'll see it in the catheter in the bed. Pericarditis, ECG changes, as I said, those tented T waves from the high potassium. You'll have either a complete lack of or a very much reduced urine volume. So oliguria being reduced urine volume, and that pruritus from the excess urea, the real itching under the skin. Chronic kidney disease, on the other hand, is obviously the other type of renal failure that we've talked about. It occurs over a period of longer than 3 months after the initial insult. So that's in comparison to AKI, which is going to be kind of weeks to months. Days to weeks. Major causes being diabetes, high blood pressure, putting stress on the renal artery, and glomerulonephritis. It is chronic, it is progressive, and you cannot go back from it. So it's really, really important to manage that blood pressure while it's still kind of in the manageable range. And you get a gradual reduction in the number of functioning nephrons. So CKD is measured in 5 stages, and once you get a GFR of less than 15 mils per minute, so that's stage 5, that's when you're really in the kind of end stage of renal failure. Stage 1, on the other hand, is when you've still got a normal GFR of over 90, but you've still got some of those histopathological changes. End stage renal failure is where you need measures that are going to help you with your renal function, because you can't manage it on your own any longer. So that's going to require dialysis. And I'm hoping that you'll go through that in lectures with the medical school. But eventually the only cure is transplantation. So it's really important to stop it getting to that stage. Okay, renal tubular acidosis, as we talked about before, is the intrarenal mechanism, or for most of them, the intrarenal mechanism of AKI. And it can be quite confusing, and it's not going to have too many marks, but it will have some. And once you've got the hang of it, it's just 3 marks. So we'll go through it really quickly. Don't ask me why there's not a type 3. I have absolutely no idea. So there's 3 types: type 1, type 2, and type 4. We will start with type 4, which is the easiest. So that is best described as hypoaldosteronism, which is, as you'll remember, the opposite of cons. So not enough aldosterone to go around. And what that means is, as with all 3 of these, you get a metabolic acidosis. You get acidic urine as well, and that's because you're excreting too much sodium. You're not retaining enough sodium, which means that the potassium is all staying within your blood. Okay, so hopefully that should make sense mechanistically. You've not got enough cation exchange in the distal tubule, so you're keeping too much potassium on board and excreting too much sodium because not enough aldosterone. And that can be for a number of causes. Not enough, like the whole RAS system is messed up, or something that's just related to aldosterone. Okay, so then if we go to type 1, that's also an issue in the distal tubule, and is also a metabolic acidosis, but the urine pH will be alkaline, and that's because you've got less hydrogen secretion in the distal tubule. So you'll end up secreting that potassium and keeping, and getting rid of the hydrogen. So you'll so keeping the hydrogen on board, and so you'll end up with alkaline urine. Hopefully that makes sense. And then the second type, type 2, is essentially the complete opposite. So the issue is not enough resorption of bicarb in the proximal tubule. So you end up with that complete opposite mechanism. You've still got a metabolic acidosis, as you do with all of these kidney things, but you have that acidic urine because you're keeping hydrogen on board, and you've still got that low or normal potassium. The renal stones happen in type 1 because, let me show you, you've got this going on. So renal stones come up so much in lab meds, and you need to know this is a barn door question, that 70% of stones are made of calcium oxalate, and that's going to be a question that comes up time and time again. Just learn it. May or may not have calcium phosphate involved as well, depends on the pathology, but calcium oxalate is just standard. Might have some of those triple stones, might have uric acid stones if you've got underlying pathology such as gout or something like that, but pretty much calcium oxalate. The symptoms, again, you should really think of these keywords, and as soon as you hear these keywords, you need to be thinking kidney stones. So it starts at the back and radiates to the front. Extreme pain. People say it's the worst pain they've ever had, and it is loin to groin. And I've always heard that and never really kind of thought about what it means. But patients, when you talk to them, will kind of make this motion on their side and point from up here or on their back all the way down to their groin area, and say that it kind of feels like it will pretty much always only be on one side, but it's really agonizing down that straight line. You might get blood in the urine. You might end up with complete obstruction, so that'll give you hydronephrosis, which is really easy to diagnose on ultrasound, and possible chronic infection. So that'll be chronic, like recurrent UTIs, depending where the stone is, and pyelonephritis. And the causes should be quite self-explanatory. Too much of the solute, not enough of the solvent. Nidus is the presence of a focus of bacteria, so an abscess or something like that, and obstruction, as we said. So not enough flow of urine. So is everyone happy with that? Oh, okay, I will take that as a yes. Cool, thank you. Okay, So next we'll talk about the renal syndromes, not necessarily causing AKI or CKD, but very much might be. Really important to think about these as causes. They might get taught to you as 3 distinct conditions, but it's a lot easier if, as with the acute coronary syndromes that we talked about yesterday, it's a lot easier to think of them as a spectrum. So we'll start with nephrotic syndrome. For ages, I didn't think really about what the actual words meant. I just tried too hard to learn them. Nephrotic syndrome, literally just too much protein leaking out from the blood into the urine. That is the basis of everything. You'll end up with this key triad, which you need to know. So that's edema. You'll see a patient with the classic puffy hands and feet, pitting edema on the shins. So that'll be really, really obvious in any of your exams. Obviously your patients this year won't have signs, but in an OSCE or in bedside teaching or anything like that, you'll see that edema. On blood tests, you'll have hypoalbuminemia. So that's less than 30 grams per litre, and proteinuria. So that's more than 3.5 grams a day. Don't necessarily need to know those numbers, but you really need to know that that's the triad of nephrotic syndrome, and you're not going to diagnose that without seeing all 3 of those things, or at least, having an idea that they're meant to be there. So on urinalysis, tons of protein, loads and loads and loads of protein. And if the nephrotic syndrome is chronic, then that could end up in a bit of a longer term malnourishment, some muscle wasting, that sort of thing. The urine will appear frothy, and that will be always in the question stem. Person presents with newly frothy urine, and you're thinking, oh, but that's exactly what this is. In children, the most common cause of nephrotic syndrome is minimal change disease, and that basically does exactly what it says on the tin. It pretty much nothing changes. You just end up with nephrotic syndrome for a bit, often secondary to an infection, and then it self-resolves. Might not self-resolve, you might need to give steroids or something like that, but it's not going to kill you. In adults, the most common is membranous nephropathy. So that's where you get these IgG deposits after infection. So that could be bacterial, viral, or parasitic. Autoimmune attacks, so things like lupus and some cancers. I think especially lung cancer is a bit of a culprit in this. Those are the 2 big ones. Other ones that it's important to know buzzwords for are focal segmental glomerulosclerosis. So that's where you'll get this real scarring of specific areas of the kidney. And if on a question stem, they've done a biopsy and they tell you about the histology of the cells in the kidney, and you see that the cells have this onion skin appearance, that is FSGS. Don't ask me why. I have never seen a slide that actually looks like onion skin, but if they say it looks like onion skin, then it is this. Diabetes is another cause. For this, it's really, really easy to just test the urinary albumin to creatinine ratio. And for diabetes, I think it can end up at something like 30-1. So that's a good one to look out for, and a really good answer if they say, what would be your first test to see if it's diabetes? Stick that one in there. And amyloid is another one. And then this is something to go away and have a look at in your own time, but it's just something that helps kind of tie together all of the different reasons and the way that they fit together. So nephritic syndrome, on the other hand, is those irritated kidneys that might give you some of the same things as nephrotic syndrome, but crucially won't give you hematuria. Will give you hematuria. So nephritic syndrome, blood in the urine. If you get blood, it's not nephrotic, really. So the key difference is blood in the urine, high blood pressure, for which we're not actually sure the mechanism. So it's probably thought that you literally just end up not filtering enough because the kidneys aren't happy, but it's possible that there's also an aldosterone thing going on in there. Sorry, a renin thing going on in there. And the proteinuria is a bit milder. So you'll still have more protein than you should, but it's not the crazy amounts that you see in nephrotic syndrome. Crucially, you'll also see red cell casts on histology of the urine, which obviously relates to the fact that there is blood in the urine. Key causes of nephritic syndrome. So you've got this post-infectious picture, glomerulonephritis, and a real classic is you'll have a sore throat, a patient who comes in with a sore throat, maybe a week or so ago. They might have even been tested, and it might turn out that they've had strep somewhere along the line 2 or 3 weeks ago. And then they turn up with this nephritic picture, and that is going to be PIG. IgA nephropathy also comes up and can sometimes be actually quite hard to distinguish from minimal change disease, but it sets on a lot quicker than that. 1 to 2 days after infection, quite common in children. You'll just instantly get this picture. And then lupus and things like that. This is small print, but it is important just to really quickly talk about vasculitic glomerulonephritis, and that's rapidly progressive, really severe. You won't see a lot of this, and you might not get any questions on it, but it's really important to know that you'll get this fibrinoid necrosis and crescent formation on histopathology. So you'll get these proliferations of epithelial cells in Bowman's space with fibrin and inflammatory cells. And that's when it's time to start thinking about vasculitic causes. During the immunodeficiency bit a bit later, we'll talk about vasculitis and how that relates to the kidneys again. That's why these two bits are together in the lecture. But just bear that in mind for now. This is a table that I found really helpful. I would advise not trying to I'm a big fan of just randomly learning stuff, cramming it, but I would advise against doing that for this. It's a lot more helpful if you try and think about what's actually going on behind the scenes, and then that will tell you all of the typical features without you having to learn them. So the third in this spectrum, which I would say is kind of in between nephrotic and nephritic, is this tubulointerstitial nephritis. So this is something that you should think of as an inflammatory/allergic condition, maybe even like a hypersensitivity type picture, if that helps you. You'll really often, especially in a multiple choice exam, you'll see drugs mentioned in the history, particularly if a patient has taken a new drug for the first time, or if they're really overusing NSAIDs for pain or inflammation or something like that. So you'll get symptoms that might sound a little bit, they might almost ring alarm bells for diabetes, but it will be in a patient that you wouldn't expect to randomly develop diabetes, and will come on a lot quicker as well. So that, and straight after drugs. So that'll be polyuria, nocturia, thirst, and on biopsy in the histo, you'll see inflammatory cells with infiltrate. As I said, often caused by inflammatory or allergic reaction to drugs, especially PPIs. So think omeprazole, antibiotics, and NSAIDs. As soon as it says the patient's been taking a ton of ibuprofen for their ankle pain and now is rocked up with blood in their urine, think about this. You won't get those casts in the urine, but you may still get blood in the urine. You'll have a raised blood urea nitrogen and creatinine, and you won't get that infective picture. You will get sterile changes. Okay, so moving on completely, we'll talk now about kidney tumours. There's not an awful lot you need to know about these, just a couple of really key facts. So you'll have covered the benign tumours. There's the papillary adenoma, there's the angiomyolipoma, and the oncocytoma. Those all have very distinct pictures that they will tell you in the stem. You know what papillary tumours look like. They're all finger-like. The blood, muscle, and fat that is literally in the name of the angiomyolipoma, and the oncocytoma presents as a brown tan mass that when you cut it up, it is literally just brown. Malignancy-wise, the most common by far is the renal cell carcinoma. It is most likely going to be that if you're asked in a question what the pathology is, if it's a malignant kidney tumour. So 2 out of 3 affected people are of the older generation, so over 65. Being male is a risk factor. Smoking doubles your risk. So those 3, age, male sex, and smoking, to be honest, are pretty good guesses for most cancers, but they're the risk factors. Others include inherited genetic mutations. You might remember von Hippel-Lindau from preclinical, and end-stage kidney disease. So as we talked about earlier, reaching that GFR of below 15, stage 5, puts you pretty much in the category of people who are going to need to start dialysis, and those people are at a higher risk for tumours. I actually don't know whether that's because of the dialysis or just because your kidneys are so destroyed by that point. With renal cell carcinoma, the textbooks, especially the older ones, talk about this classic triad of hematuria, loin pain, and a mass. Obviously, those first 2 symptoms might also point you towards a kidney stone. But the 3 of those together actually only come up in about 10% of cases. You might see any combination of those or none at all. Hematuria is massively the most common symptom, but by that point it's already quite late in the disease process. So I wouldn't take those 3 things to mean that if you see them it's cancer, if you don't it's not. It doesn't work like that. And then this worst to best thing here is tells you about the prognosis of the types. Okay, so children's renal tumours, if you see a question stem where a child has presented with a new abdominal mass, maybe feeling a bit unwell, but might not have any real cancer symptoms yet, but they do have that really palpable mass, especially in their back. Think Wilms tumor. This is massively the most common abdominal tumor of the child. It's still rare, but one of the commonest blastomas. So if you remember, that's the kind of precursor fetal cells, which is why it's most common in children. Very rarely older than that. It's pretty aggressive. The 5-year survival used to be 20% and is now 90%, which is huge, with very, very aggressive chemo and radio. So it is nasty. And then you've got these tumours of the collecting duct system. Embryologically, the renal pelvis and the bladder come from the same thing. And it's important to think about when you think about cancer, and especially with things like this. So TCC of the bladder is pretty much identical to the urothelial carcinoma of the renal pelvis. It rises from the lining, the transitional epithelium of the renal pelvis or the ureter. It's pretty difficult to diagnose because it's quite hard to get a biopsy from there, and difficult to differentiate radiologically, but you will find, especially because it's one of the more likely things to come up in the ureter itself, that you might get those really similar obstructive pictures. So post-renal AKI, or even CKD, maybe a picture similar to a kidney stone, or the development of kidney stones from the renal stasis because of the obstruction. Yeah, cool. Bladder, as I've just talked about, transitional cell carcinoma is the bladder cancer. If they're asking you about bladder cancer, it's that. Don't even really consider anything else. It's most common between ages 50 and 80. Gender ratio, male to female, of 4:1. It can look like pretty much any cell, to be honest. They differentiate all over the place and have a lot of mixed features. The question stem probably won't tell you what they are because it's just so different for every case. The huge risk factors for bladder cancer are smoking and aniline dye exposure. Such a random one, just 2 that you have to learn. Aniline dye apparently is used in loads of factories and stuff for loads of different things. So maybe if it tells you that they're a kind of floor factory worker, then just have a think about that. And then this is what you'll start to see on the histopathology. this is one of the cancers where even when it is technically in situ, so hopefully you'll remember that for most cancers, if we describe them as being in situ, they're actually more precursors to cancer than cancers themselves. So for example, you'll come to this in the new year, but a ductal carcinoma in situ is a precursor to breast cancer, and things like that. But in this case, in situ is still cancer. You've got this squamous carcinoma of the bladder. The only time really to think about this is if you see the classic squamous question stem of keratin pearls and intracellular bridges on histology, and a history of schistosomiasis. So yeah, adenocarcinoma, if you've got remnants of the fetal urogenital system, then it might be that, but honestly, I've never seen it come up and I wouldn't expect it to come up. Yeah. So if we're still thinking about obstruction of that whole system, then one of the most common reasons is benign hyperplasia of the prostate. That, as it says on the tin, is benign and is so common. One in, I think it's 3 and 4 men between 70 and 80 have BPH. And it actually came up in our OSCE last year. That was one of the histories that we had to take. So it will come up in some form, in some exam. The prostate, as you know, surrounds the urethra at the base of the bladder. It has secretory glands, which is where PSA is made. And that is a good but pretty non-specific marker for prostate growth. So you can use it to kind of track growth over time, but it's really not standardized between people. It's embedded in smooth muscle and fibrous tissue. The inner zone is where you get BPH, and the outer zone is where carcinoma tends to happen, and that's a way that you can differentiate. 1 in 10 requires surgical treatment, but yeah, so many people have it that that's actually not that big of a number. These are the symptoms that you'll get, kind of similar to UTI symptoms, so definitely be thinking about UTI as well. They may also have both, given that they have post-renal obstruction. Yeah, an older man who's got these symptoms could well have one or both of BPH and a UTI. These are the complications. So kind of similar to heart failure in a way, where you get hypertrophy of the cardiac muscle because it's having to work harder to push past. You'll get the same with bladder muscle. Urinary retention, so might need regular catheterization, recurrent infection, stones, and hydronephrosis, as we talked about before. Prostate cancer is the commonest cancer in men in the UK and is particularly common in males aged 75 to 79, but it is one of the least aggressive cancers, and far more people die with an undetected or unmanaged prostate cancer than they do from it. 95% of prostate cancers are adenocarcinomas, which hopefully you should be starting to piece together from the fact that the prostate has those glands, and adenocarcinomas appear in organs and tissues with glands. Risk factors include a family history, being of Afro-Caribbean descent, having the BRCA2 mutation or Lynch syndrome. It'll often be asymptomatic. It's good that we're doing screening now because it does just hide away for so long. You might get hematuria, but that's pretty non-specific. And then those metastatic symptoms once it's got later on down the line. So diagnosis can also be quite difficult. A DRE is a good start, but pretty hard on that sort of exam to distinguish between prostate cancer and BPH. Serum PSA, as I said before, is not very specific because it can be raised by literally anything that makes the prostate bigger, or just with age, to be honest. MRI and those horrible needle biopsies. and it is Gleason grading, which is important to know just because they like you to know the names of the grading systems. Just learn those. And you don't need to know what the systems are, you just need to know their names. Okay. Testicular tumours, as you know from every lump and bump, it's worrying if it's painless, hard, irregular, kind of craggy, quite big, and obviously might have those metastatic symptoms. Same with this, painless testicular mass might have a regional ache or pain, particularly if it's got itself into the lymph nodes or digging into blood supply. 2 to 3% of patients have metastatic symptoms, and 2% have bilateral testicular tumours, which are most often going to be genetic. Diagnosis is by ultrasound and tumour markers. So you'll probably have heard before that taking a urine test as a person with a penis means that, and having a positive pregnancy test can be a sign of testicular cancer. Not particularly specific, but beta HCG is raised in choriocarcinoma and can go up with some seminomas. So alpha fetoprotein is raised in yolk sac tumours, and LDH is a very non-specific tumour burden marker that is pretty much relevant to every tumour in the body. Over 90% of testicular tumours are germ cell. So let's focus on that first, or just full stop, to be honest. Most of them are a mix of seminomas and non-seminomas. Seminomas are over 50% of germ cell tumours. They arise in most often people aged 20 to 55 and drop off after that. Average age of 40. They usually spread via the lymphatic system, and particularly firstly to the retroperitoneal lymph nodes. So if on CT, for example, you were to have this retroperitoneal lymph node picture, then think about testicular cancer. Seminomas specifically. Non-seminomas, meanwhile, appear in slightly younger adults, and so they'll be cells of more embryological origin. So in an exam, you might have a question, because we had a weird number of questions where a sort of 15-year-old boy would present having noticed a lump after playing rugby or something. It would always be something to throw you off, to make you think torsion. But he'd have a lump, a painless lump, and it would often be a non-seminomatous tumour of an embryological origin, so yolk sac, choriocarcinoma, teratoma, all that stuff. Tends to spread via blood rather than lymphatics, so that's a key way of telling the two apart. That's pretty much, to be honest, the only way that they'll ask you to tell them apart. Risk factors include undescended testes, which are associated with 10% of cases. And that's often because of the kind of difference in temperature between where the testicles are meant to be and where they actually stay in cryptorchidism. So, infertility is another kind of link to that. Personal history of testicular cancer, family history of testicular cancer, and that precursor lesion that I was talking about earlier, the old in situ, that applies to a lot of these cancers. So in this case, it's the germ cell neoplasia in situ. And on histology for that, you'll see dysplasia that hasn't yet turned into cancer. So that's the kidneys. Bit of a whistle-stop tour. Those are the most important things. And once you've got your head around those, and those like real buzzwords like the onion skin and all that, should make sense. Obviously, we had talked about doing a break in between, but this one shouldn't be too long, so I can just keep going if people want me to. Yeah, put a thumbs up if you want me to keep going, and otherwise I can give you a break. Cool. Cool. Okay. Right, let's keep going then, and this should be over quite soon. The immunology part of the syllabus was one of my favourites, and that partly was because of how well I thought it was taught. I don't know if on Canvas you've been given those revision sheets yet, the ones that get made that just have absolutely everything on that is kind of perfectly organised. If you have those, use them because they're literally all you need to know. I think there was like 3 or 4 3-page documents, and they were just amazing. But we'll go through some of these high yield bits now. Just as a word of warning, obviously you'll have been told, I'm assuming, that the LabMed app that is made for you, obviously it's great, but for most of the content, to be fair, but specifically immunology, the level of the questions is that tad bit easier than that of the actual exam. So it's great for practice and great for getting to grips with the style of the question. But for immunology and for a lot of the others, don't get complacent with the LabMed app. Make sure that you've done this sort of content in detail because it will come up, especially hematology, and is very useful for you. So you'll know all of this. The 4 types of hypersensitivity reactions are the most basic LabMed stuff. This type 1 classic allergy, which is the cause of anaphylaxis and most allergies, all of that stuff. Is IgE.
Oh, shit.
Don't worry. What was I saying? They're IgE mediated, and you'll see mast cell degranulation and release of histamine. A question that sometimes comes up, it probably won't come up on LabMed, but it will come up in the AKT, is that if you've got a patient who's having an anaphylactic reaction or a really severe allergic reaction, and you think they're having that, but you're not quite sure, a really good way of knowing that for the future is to get a quick blood test off them, get it and order a tryptase. And from that, you'll be able to understand the mast cell degranulation and then have a definitive answer as to whether or not this was a hypersensitivity reaction. Type 2 is antibody mediated and involves a lot of the autoimmune stuff. There's a really nice list here of the different antibodies to the different complexes. Type 3 is immune complex mediated. That's even slower. The classic for that is lupus, and you're probably going to need a biopsy. Type 4 is T-cell mediated, and that's where you've got your allergic contact dermatitises. So the classic question of a woman wears a new belt and ends up with a really itchy line around her stomach, and then she's got a nickel type 4 hypersensitivity reaction, and you can just say it's T-cell mediated. An example being the MON2 test in TB, and is diagnosed by patch testing. Anaphylaxis is, as you'll know, the severe and life-threatening allergic reaction. It's a type 1 hypersensitivity reaction. You get these whole body systemic symptoms, cardiovascular, resp, skin, and GI symptoms. All of these can come up and can come on really, really, really fast. Caused by either allergic mast cell triggers such as venom or food, and that has to have had prior exposure, prior sensitization. So these people will often have tried peanut butter once with no reaction and then had it again and ended up needing an EpiPen. The second option is non-allergic mast cell triggers such as the anaphylactoids, which can include the radio-opaque contrast media that they use in hospitals, which is unfortunate, NSAIDs, aspirin, and for those you don't need any prior sensitization. The management, this is one of the very, very, very few bits of management you need for LabMed, and that is that the adrenaline you need to deliver is intramuscular and it is 1 in 1,000 strength. The only other bit of information that you need is that for cardiac arrest, the adrenaline you need is IV, not IM, and 1 in 10,000 strength. Hoping that makes sense. Cool. Okay, vasculitis, obviously, is dysfunction in the immune system. And it took me a bit of time to get my head around. I think maybe because it's not really one of those things that's ever talked about outside of our course. But it does help once you understand it. And what I've tried to do is highlight one kind of key trigger word for each type of vasculitis that should get you thinking that it's that one instantly. So it is inflammation in and around the walls of blood vessels, which leads to damage or destruction of the vessel wall. You'll get lots of scarring, narrowing, weakening, possibly even clotting and tissue ischemia. Could be localized, could be systemic. For primary, there's no obvious cause associated with anchor antibodies, which we'll come on to, immune complexes or T-cell mediated disease. And then secondary is often following infection, malignancy, drug reactions. It'll be really, really obvious in the question stem if they want you to know that. Yeah, fine. So we'll start with the large vessel vasculitis. And as you know, there are 2 of those. The first, which I think is probably the most common one to come up in a question because it's easy to ask about, is this giant cell arteritis, also known as temporal arteritis. And that is focal chronic granulomatous inflammation with T cells and giant cells. And on biopsy, this is something that they really will ask you. Lesions are focal and might be missed. So you might biopsy, ultrasound biopsy, the temporal artery and not find anything despite thinking it's GCA. And the reason for that is that there are skip lesions. So you need to make sure to test multiple areas of the artery. Clinical features, it'll often be a woman over 55. They'll present with a headache and they might even present with sudden onset blindness. If they don't in the question present with sudden onset blindness, then you need to remember that the next thing that's going to happen is sudden onset blindness. So it'll be a question like, what do you need to do next? What do you need to stop from happening? What's the most immediate danger? It's that sudden blindness. A really common clinical feature that I think got missed, or at least I missed it in the teaching, was that in 50% of people, you'll get also this polymyalgia rheumatica. So it's not just all in the head, in the temporal artery. You'll get this muscle pain and stiffness in the shoulder and hips. And I think it's really useful to know that if you get a question in which an older lady has a sudden headache, but she's not lost consciousness or anything like that, you're not worried about a hemorrhage or like anything like that. And she says that she's having real difficulty all of a sudden getting up out of her chair. She's got this kind of real pain in her shoulders and hips. Think GCA. It's not just all head and neck related. And if you have a feel, you might get quite sore, firm, superficial temporal arteries. Urgent prednisolone needed to prevent blindness. That is the first line that, like, if they say what is the initial management, prednisolone, give it, bosh. You don't need to know the numbers, but you can learn them if you like. Good prognosis as long as you've given that prednisolone on time. Takayasu disease is the other type of large vessel vasculitis, also known as aortic arch syndrome for good reason. It's predominantly and will probably be in the question as a patient, probably a woman of Far Eastern ethnicity, often less than 40, a lot younger than you'd expect to be having these symptoms out of the blue, who have claudication when they should not. And claudication means a sudden kind of blockage of the vessels leading probably to a limb, but also could be elsewhere. So that's the non-smokers, the non-diabetics that you wouldn't expect to have blockages at that age. It's granulomatous vasculitis of the aortic arch and the origins of the great arteries. So you'll have this pre-pulseless phase, which you'll just see symptoms of poor perfusion. So dyspnea or exertion, a cough, tachycardia, which is obviously so non-specific. Every patient and their nan has that. And then after a bit, you'll suddenly have this subacute phase, fever, malaise, night sweats, might even get you worrying about malignancy. But the really key one, which is why it's highlighted, is this upper and lower limb claudication. Suddenly you've got pain when you're walking, or numbness when you're walking, or one of your arms has gone all floppy and weak and weird. And it might be intermittent, so it'll come back again. But you'll be reading the question stem and just think it's all a bit weird. Think about this. Investigation, angiography and biopsy, but if you're doing it bedside, and you use the bell of your stethoscope to listen for subclavian bruits, so that's around here. And then treatment, as for most of the immune dysfunctions, is steroids and cyclophosphamide. Those are your barn door treatments. And then we've got two types of medium vessel vasculitis. So we've got polyarteritis nodosa, and that is necrotizing inflammation of the media of arteries supplying the viscera. You might get aneurysm formation, thrombosis, ischemia. You've got this immune complex deposition. It obviously, again, as you can see from the clinical features list, might look like a bit of a mess. It kind of feels like every time you read a vasculitis slide, you get pain, you get skin, you get, and it can be quite hard to tell them apart. The really key one is this mesenteric ischemia, which will probably come up in the question if they're asking you about PN. So you'll get this abdominal pain because you've got a thrombus or ischemia, or a blockage causing mesenteric ischemia, and you'll have this really awful sudden onset, front of the whole abdomen, tummy pain. And then with that, you'll have the fever, the muscle aches, the joint aches, the weight loss, the hypertension, renal insufficiency. The list really does just go on. Neurologically, mononeuritis multiplex is where one nerve at a time experiences neuropathy, and it will probably progress and you'll add more and more and more neurons. So you might get one real specific part of you being tingling or numb or something like that, and then another one will join in, and then another one will join in. And that's kind of different to polyneuropathy, which starts pretty much all at the same time. And then orchitis, so that's swelling of the testicles. Linked to Hep B, so have a look at Hep B serology. You can find those microaneurysms on mesenteric and renal angiography, and you will have no anchor antibodies, which again we will come on to later. And then those necrotizing inflammatory changes on biopsy. Treatment, prednisolone plus or minus cyclophosphamide. Prognosis varies. Kawasaki disease. If you see a child under 5 with prolonged fever, weirdly long fever, why is it not going away? And why is it not going down with paracetamol, Calpol? And mucocutaneous changes, so real sore lips, tongue, bright red, ulcerating, horrible. Think Kawasaki disease. There's actually signs in the emergency department at the JR that encourage you to think, if you see a child who rocks up with a really nasty fever and these symptoms, don't just think flu. Make sure that you've checked for Kawasaki disease. That's how important this is. So you've got this high spiking fever, conjunctivitis in both eyes, which, as with everything in medicine, bilaterality is rare. You need to be thinking of something a little bit deeper than just conjunctivitis if it's happening in both eyes at the same time. Mucosal damage to the lips and tongue, rashes on the hands and feet, cervical lymphadenopathy, but obviously that's common. And a big major complication is coronary arteritis in 20% of cases. Obviously, I've already talked about it being most commonly children under 5. Obviously, it's unlikely that a child under 5 will have a myocardial infarction, but a young person who's presented with a fever and you're just thinking, what's wrong with you? And you look at their ECG and they've either had an MI or they've got myocarditis, think Kawasaki. There's no specific test. ESR and CRP will be up because of the inflammation. And then you're going to need high dose IV immunoglobulin and steroids. So we're nearly done, I promise. So we've got 4 types of small vessel vasculitis. The first being granulomatosis with polyangiitis, also called Wegener's. It's one of the 2 that is C-ANCA antibody positive. And it's just granulomatous vasculitis everywhere. In the question stem, it will just look like a mess of symptoms that are all ENT but don't seem to have an infectious cause. So particularly upper airways, you'll get this sinusitis, otitis, nasal crusting, maybe even a collapse of the nasal bridge. You're really just unwell, joint pain, muscle pain. Something that's pathognomic for GPA is, or not pathognomic, sorry, is quite, should be quite synonymous with GPA, is cannonball lesions in the lungs. Does happen with other stuff as well, but cannonball lesions in the lungs with cavitation and coughing up blood. In the kidneys, you'll get this glomerulonephritis picture. Investigations, you'll be C-ANCA positive, hematuria, proteinuria, you'll see it on the chest x-ray and a CT of the sinuses, and you need a biopsy as the gold standard. And again, corticosteroids and cyclophosphamide. The one that is P-ANCA positive, which don't hang your hat on this because P-ANCA is quite non-specific, but if you're thinking vasculitis and it's P-ANCA positive, it's probably eGPA, eosinophilic GPA, the eosinophilic version of the one before, also called Churg-Strauss syndrome, is necrotizing vasculitis of the small and medium arteries with intimal inflammation with eosinophilic infiltrates, which will be obvious on biopsy. If you see a picture of mononeuritis multiplex, which I explained before, think eGPA. You'll get this weird allergic prodrome of several years with kind of asthmatic, atopic kind of symptoms, often involving the sinuses and upper airways again. Again, corticosteroids and cyclophosphamide. So by this point, the only way you're really differentiating these is with their blood tests, with their autoimmune panels. Just to quickly remind you, ANCA are anti-neutrophilic cytoplasmic antibodies, which are antibodies against substances found in the cytoplasm for C-ANCA, or in the nucleus of neutrophils for P-ANCA. And you can see from this table what they act against. As we've talked about already, P-ANCA is a bit less specific. Right. Microscopic polyangiitis is the other one, which is C-ANCA positive. It is the most common vasculitis. You'll see this glomerulonephritis picture, which we talked about earlier, with hypertension and renal insufficiency. So if the kidneys are suddenly just packed up out of nowhere, start thinking this. They have a short prodrome of fever, malaise, joint pain, muscle pain. So as we've talked about before, it could be one of those other immune-mediated nephropathies. But just have a think about this, especially if it's severe. Again, extrarenal manifestations like polyneuritis multiplex, and another one is pulmonary hemorrhage. So if you're suddenly bleeding when you're coughing, think this. Again, corticosteroids and cyclophosphamide, there is a pattern here. The last vasculitis, which is ANCA negative, it's the only small vessel vasculitis which is ANCA negative, is Henoch-Schönlein purpura. And that is something that you'll often see in children and might be confused for other skin things, which I'll come on to in a second. It's IgA containing immune complexes in the affected tissues. So pretty much affects the kidneys, GI system, and skin. Often in small children, about 3 years, most often in boys. often preceded by an upper respiratory tract infection. And luckily, because of that, it's self-limiting and treatment often is not needed. You'll get this GI hemorrhage with colic and vomiting, depending where in the tract this bleeding is happening. You might get hematemesis or melena. Renal nephritis, as we talked about before, and migratory arthralgia in the joints. So it's moving from the peripheries into the center. These kids are just in pain, they're not happy. It's a clinical diagnosis with a biopsy of the skin and gut. What I was going to say before is that the skin changes can often look like the DIC that you'll have covered in hematology, which is obviously a lot more severe, and is the sort of rash that you'll see in meningitis, and DIC is what causes the rash in meningitis. So if you see a child with a rash that really just doesn't look good, does not spark joy, you're thinking, I don't know if they're a meningitis kid, but they just don't seem unwell enough for it. And they've been in and out of hospital, probably misdiagnosed a couple of times. They've had this temperature and just been unwell and sore and got this blood in their urine. Think this. Okay, really quick talk about a couple of the autoimmune diseases. So we've got Sjogren's first, and that's autoimmune destruction of the exocrine glands. Can be idiopathic, can be associated with lupus, rheumatoid arthritis, or scleroderma, which are some of the other diseases. Clinical features are particularly those sicker symptoms, so the dry eyes and the dry mouth. You also have joint pain and inflammation and fatigue. The real good test for this is antibodies to Rho and LAR, specifically Rho. And if you if you get given the results for an autoimmune panel, you'll have Rho and LAR on there, and it will be pretty obvious. Cool. Scleroderma is one that I've never actually seen. It's a chronic fibrosing, so scarring disease due to endothelial activation of CD4 T cells and monocytes. Don't know what's happened to the text there. Sorry about that. Two types. You've got the limited type. So you've got these anti-centromere antibodies, which will also be on the autoimmune panel, affecting the skin, giving you a beak-like nose and crest syndrome, which we will come on to in a minute. And then you've got diffuse scleroderma, which is more severe, with these anti-SCL70 antibodies affecting the esophagus, small bowel, kidney, lung, and heart. Crest syndrome is this. You've got calcinosis, Raynaud's, esophageal dysfunction, sclerodactyly, and telangiectasis. Cool. And then we're probably like 4 or 5 slides off from the end at this point. Well done for sticking with it. Immunodeficiency, really quickly. You'll again have seen the really good resources on Canvas to do with this, but just to take you through the most common things that they'll throw at you. So X-linked agammaglobulinemia, also called Bruton's disease, is a developmental arrest at the pre-B cell stage. So those cells just don't even enter the circulation. So it is specific to B cells and antibodies, and an absence of those, just none on a full blood count. You'll get a full blood count and it'll just say 0. Obviously, because it's X-linked, most common and most severe in males. You won't really, in a lab med question, have a female with this because it's just not high yield enough. You'll get recurrent pneumonia, ear infection, sinusitis, conjunctivitis, meningitis. So a lot of stuff up here. And then those GI infections as well. Hereditary angioedema. I don't have much to say about that. You just end up with swelling following pretty much anything, but like a weird amount of swelling. SCID, Typically the question will be a young baby who is failing to thrive, not growing, not meeting its milestones, recurrent chest infections and recurrent diarrhea, probably recurrent ear infections as well, an absolute lymphocyte count under 2, and particularly in the absence of a positive HIV test. This one you won't really see unless they're on some mega cool treatment. You won't really see in a question stem in a person that's older than a few years old, because they just, it's a pretty severe disease and often unsurvivable. You might see in the question stem that they have consanguinity in their family. CVID is most likely to affect young adult patients with hypogammaglobulinemias. So that's low immunoglobulins, but across the board. So low IgA, low IgM, low IgG. And you get a lot of sinopulmonary infections. So that's your sinuses and your lungs. And it just keeps coming back, particularly every winter. They might need a bit of a hospital stay a couple times a year, but should be all right. And then the last one, you've got leukocyte adhesion deficiency, which is a defect in neutrophil chemotaxis, so stops the neutrophil rolling through the blood vessels. Causes, the first sign will be delayed umbilical cord detachment. So you'll have a history from a mum who says, oh yeah, no, there were no issues in my pregnancy, although the doctor did say that the umbilical cord was quite difficult to detach. And you'll go, okay. They don't get any swelling, redness, pus when wounded, which you should. So that'll be a bit of a giveaway. So have a look at this. I've kind of already given it away, but this is a really, really standard question that you'll see. So I'm hoping that you've all read it and instantly thought common variable immunodeficiency, so CVID. If we go through it, it's obviously, you know, annoying for her, but pretty minor on the scale of immunodeficiency disorders. She's a woman, so we're instantly not thinking Brutons. We are looking at the blood tests and seeing pan hypogammaglobulinemia, so low all of the Igs, high T cells in order to make up for the lack of everything else, and low B cells as well. Electrophoresis of the serum and urine being normal is important because we've not got funny clots going on, a weird vasculitis picture, we've not got sickle cell, we're not having any sharing of the blood cells. Any spleen disorders would show up on there. And then yeah, so you should be thinking CVID. One more slide. Can I please ask everyone to fill in this feedback form? Thank you so much for coming. There is only one more slide and I hope you've enjoyed it. Yeah, please let me know what you think. And then you'll all get the slides in return for filling this out. So thank you. Cool. I'm hoping you've all scanned this by now, so I will just show you that last slide. And this is just to show you a summary of the things that people with other types of immunocompromise will be more susceptible to. So the asplenic people who might have had trauma to the spleen, or their spleen removed, or, you know, any number of reasons, are most susceptible to encapsulated organisms, and will show you Howell Jolly bodies on blood film. Sorry. So strep pneumoniae, you'll need to manage their sepsis with ceftriaxone. Haemophilus influenzae, Neisseria meningitidis, and malaria, all nasty for people without spleens or without working spleens. People with neutropenia, so for example, people with some of the immunodeficiency disorders, but also for people on chemotherapy, things like that. Candida, Aspergillus, so Candida being thrush, Aspergillus giving you quite an atypical picture, including a nasty pneumonia, and Pseudomonas, which, as you know, can only be treated with these 5 antibiotics. And then finally, HIV. These people are susceptible to John Cunningham virus, which causes multifocal leukoencephalopathy, which leads to PML, which is nasty. Again, just have that in the back of your head for when a funky question comes up. If anyone has any questions, please do let me know, and I'll read it in the chat, or you can say it out loud. And if not, then I will go back to this QR code and you can all go and eat your dinner. Thank you very much.